Welcome to Everything Health, produced by the A. Philip Randolph Institute. Tonight's segment is sponsored by Kaiser Permanente, one of labor's premier healthcare providers. This is a conversation about health and healthcare in America. Tonight's segment will be hosted by Cleola Brown, president of the A. Philip Randolph Institute. So sit back and enjoy as together we explore everything health. And at any time during the conversation, you may post a question by using the Q&A feature located at the bottom of the Zoom application. And your question may be featured during our Q&A segment later in the show. Once again, thank you for joining us this evening as we start the show.
Good evening, APRI family and friends. Thank you for joining us tonight for another segment of Everything Health. Now, for those who tune in every week, we say a special thank you. And we hope that this week you have invited family, friends, and other relatives for this very important discussion. Our guest this evening is Dr. Burnette, who will be providing us an in-depth discussion, some insight into the disparities in the treatment, diagnosis of prostate cancer. Dr. Burnette is the Patrick Walsh Distinguished Professor of Urology and is also a professor, a surgeon at the Johns Hopkins University and Hospital. And although this is sort of an extremely short version of his accomplishments, I must tell you that he has written more than 340 original peer review articles, 50 book chapters, and 2 books related to his biomedical research and clinical activities. Dr. Burnette, every year, the A. Philip Randolph Institute always has a health symposium at our annual conference that attracts about 700 people. So for the past at least 15 years, we've been making a point to have discussions on health, and particularly African American health. And one of our previous sessions, addressed the issue of prostate cancer. And so what we did, we broke the 700 people up into 2 groups, one male, and we had a brothers only session. And then we also had a sisters only session. And then we brought folks together to talk about the impact of prostate cancer, undiagnosed, untreated, on the whole family. So this evening, we're looking forward to hearing from you, my friend, Dr. Burnette. The show is yours. Dr. Burnette.
Yes, good evening. It's certainly my pleasure to join you. Thank you for that very warm welcome, my good friend, Mr. Fred Mason. And to all the attendees, I'm very delighted to be able to present this evening. It's my honor, and certainly to follow up from that prologue. My topic has to do with prostate cancer. The intent here is to discuss this disease state that disproportionately does affect African Americans. So I think it's very apropos to present this within the webinar series, but it is also one to talk about what we're going to do about it and how we're going to address this problem. And so it reflects the healthcare system and management considerations going forward surrounding this topic. So thank you very much, and let me go ahead and begin. So hold on one moment. I hope that I am screen sharing now. All right, now we are good to go. Okay. So in terms of my objectives, I'd like to present the objectives in a threefold manner. First, to present some of the basic epidemiology. What are the facts? What are the statistics that help us understand the reality of this disease state? I'd like also to discuss with you where we can consider the sources of the problem, and particularly within the context of racial and ethnic disparity. And again, I want to emphasize that there are factors at different levels, including the healthcare system. And then I'd like to discuss with you how we need to address this in terms of diagnosis, management, and moving forward to bring forward the best outcomes among those who are disproportionately affected. And again, we're talking about racial disparities. Now, in terms of the health disparities, the national impact, by way of definition, I think we should understand that this emphasizes an increased burden of an adverse health outcome or health determinant within a specific subset of the population. The buzzwords there is the burden. It is a burden on multiple levels, and it affects a subset, again, disproportionately those of racial and ethnic minority groups. So I think this is the focus of the presentation. Keep this in mind as we go forward. There are different levels of healthcare system disparity, and this can reflect aspects having to do with the patient, the provider, and the healthcare system. And I'm going to delve into all of these different areas as we move forward. So this is kind of a systematic way of thinking this through. Now, in terms of scientific progress, it is remarkable enough to consider the irony of the fact that we are moving forward in the world of advances in healthcare and medicine and innovations in our field. But wouldn't you know that populations are increasing, and population disparities increase when there is scientific progress in medicine? Now, this whole concept reflects a presentation from my good friend and colleague Otis Brawley, who's a medical oncologist here at Johns Hopkins. And he helped, I think, bring forward kind of this concept here. The irony that as we make progress in medicine, the reality is we're not necessarily making progress for ethnic and minority groups. The fact that we see disparities that have been observed in the screening and treatment of breast and colorectal cancer, all right, two other major cancers beyond prostate cancer, whereby screening and treatment seems to disproportionately affect those disease states for our population. It's occurred as we moved into the era of precision medicine and immunotherapy. Wonderful advances we're talking about. And everybody hears this buzzword of precision medicine, which sounds like we are bringing forth the idea of medical care that is tailored specifically to patients' individual genetics and health and characteristics that may be unique to that individual. But as you may not be aware of, there's a disparity in this. And perhaps there are some who are taking advantage of this advance more than others. And I think this is an interesting conundrum that we're dealing with, that while we're making these kinds of advances, some are being left behind. Thirdly, new preventive interventions are less likely to cause significant disparate outcomes. What is this that he's remarking on? Well, this point is that there are opportunities here to address the problem if there are preventative ways of management. And this makes the point that preventative interventions are perhaps the best strategy that we may be able to overcome the disparities in care. So I'm going to talk about some of that as we go forward. Now, a bit more on statistics. This is just a nice table that presents to the group here the leading causes of death, both in males and females, okay? And what this table nicely depicts is the comparison between non-Hispanic Blacks and non-Hispanic whites for common causes of death. These include heart disease, cancer, and other common conditions from accidents, cerebrovascular diseases, which is stroke, and diabetes. Some of the top conditions, and what you can see just scanning over the table, that the death rate is disproportionately greater in Black individuals than in white individuals. A significant difference for both males and, down on the bottom, the females. This all makes the point that indeed, for cancers as well as for other conditions, the burden that is faced by African Americans in the United States is much greater. And this is a sobering fact that I think we have to just acknowledge that is the truth. Now, with regard to cancer specifically, what this table is meant to show is the estimated new cancer cases and estimated deaths for male and female African Americans. Prostate cancer leads the list among the most common cancer that African Americans will face. So in the United States, Black Americans should recognize that prostate cancer is significant. In fact, for all men of all ethnicities, prostate cancer is the leading cancer in the United States. And it represents about 30%, 1/3 of the cancers that African American men will endure. What about the death rate? Well, the point here is that prostate cancer is second in line to lung and bronchus cancers. Lung cancers do have the highest rate among cancers, but prostate cancer significantly it causes death in about 15% of all cancer-related deaths. So this makes the point here that we need to recognize the reality of prostate cancer and its significance by way of statistics. Now, in terms of the problem of prostate cancer, the racial variation is clear, both on the level of how prevalent or how much it occurs in terms of incidence rates, and as well as mortality rates. And other sobering news to tell you is that the incidence of prostate cancer among white American men is 142 per 100,000 population. For Black Americans, it's 230 per 100,000. The rate ratio is 1.62, meaning that, just for your information, about 60% greater likelihood of African American men sustaining prostate cancer. The mortality rate is even more sobering. And the rate ratio there, and you can see the numbers, is about 2.5-fold greater death rate among Black men than white men in the United States. So I present all this just to present the facts and the reality that prostate cancer disproportionately affects men of African American race. Why prostate cancer? Why is this so? And so my knowledge of the field, having been involved with prostate cancer for the past few decades, may be at least these considerations. It is likely to be a more likely aggressive disease, less likely early detection of the problem, and more likely under treatment. In terms of aggressive disease, we have various databases that we have looked up. Here I present what's called the CAPTURE database, and there's various sorts of parameters that's listed here that you can read from the slide. But the way that we evaluate prostate cancer, both clinically and pathologically, all of these kinds of parameters are just much more weighty among African American men than white American men. It does tell us possibly that there's a greater pathologic biology, tumor biology about prostate cancer, and we're still trying to figure that out. What about aspects of the healthcare system itself? Less likely early detection. Another database from the National Cancer Institute called the SEER database has shown remarkably that there appears to be possibly that African American men are not as early detected and also treated for their prostate cancer. And I'm going to have a little more to say about that in a moment. Another proposed idea here is that African American men possibly are undertreated. And there are statistics and data, literature reports out there that after adjusting for various kinds of factors, okay, adjusting for the aggressiveness level, some socioeconomic factors, comorbidities, there are still differences in treatment patterns. And therefore, that could possibly explain why African American men are undertreated for their prostate cancer and possibly sustain then a greater mortality from this disease. Now, there appear to be multiple factors that can be associated with racial variation. You had earlier seen a slide where I tried to organize our thinking about how do we think about the disease state? Do we think about the patient? Do we think about providers in the healthcare system? And the disease state reflects a whole host of variables about how aggressive it is, how far advanced it is, the extent of it, and even the PSA, which is a blood test that starts to go up very commonly in younger Black men than younger white men. So we need to be aware of how the disease state may be different and how we detect it and what biomarkers and tests that we use to pick it up. Patient factors include a host of determinants that I'm going to speak about in a moment. There are factors that relate to how patients understand getting their health checkups, but also various other conditions that I'm going to speak about in a moment. Provider factors are key as well, and I'm going to speak to that in terms of various aspects of who gets treated, how they get treated, where they get treated, all also have impact on why there could be differences in prostate cancer outcomes. So what I was alluding to a moment ago, particularly on the patient level, is social determinants of health. So this is something that this audience conceivably has heard with various other disease states that disproportionately affect African Americans. But this certainly comes into play with regard to prostate cancer. This refers to a number of different conditions having to do with how we live, how we function, how we work, and our environment that all come into play with regard to impacting the disease state for African Americans in particular. Remarkably, various sources here as listed at the bottom of the slide suggest that as much as 90% of the modifiable contributors to population health outcomes refer to social determinants of health, versus 10 to 20% having to do with healthcare access and that sort of thing. So what that means is that there are many different factors that have to do with social determinants of health. And I'm going to get into that a little bit more as to how we need to recognize this has such significant impact on prostate cancer and possibly other disease states in the African American population. I put forward here a slide that just shows you the whole range of elements here that impact our health as African Americans. Yeah, you can just read off the slide, everything that ranges from our education, our food security, the extent to which we have employment, literacy, social support, discrimination plays a role, and stress. One of the remarkable stories I'll tell you is a nice report that came out in a social health study that had to do with the graduating class of Yale undergraduates in 1970. And the amazing thing that was shown there is that within several years, among the African Americans in that graduating class, 10% had already died within several years. I'd say having the opportunity to go to someplace like Yale, a school of higher education where there should be opportunities to have an education, have income, have a better way of life. That did not necessarily impact the disproportionate effect where the percentage death rate was far lower in non-Black individuals from that graduating class. A nice, interesting study that makes the point that African Americans of all socioeconomic backgrounds can be impacted by discrimination, can be impacted by various social stressors, and can have various adverse outcomes, and that traverses as well associated economic differences in life. And this just makes the point here that there's a whole host of factors that impact the health of us African American individuals. A very sobering thought here. Now, beyond social determinants of health, there may be other aspects that have to do with decreased utilization of definitive care. And I kind of put forward a couple of ideas earlier, and this is from my attempt to do a good literature review of various other additional factors that could play roles. Is there treatment selection bias? And indeed, there is evidence to suggest that. Watchful waiting was administered at an increased 1.4 times the odd ratio in African Americans. What is watchful waiting? Well, in prostate cancer, that means that we will just wait and see what happens to you. And many times that this is an intervention for somebody who has more advanced disease or is not in good health. But the point here is that taking proactive management is less often done in the African Americans. And when African Americans potentially present with prostate cancer, are they more likely to be told, oh, just live with your disease, see what happens? And the evidence in America suggests that watchful waiting as an intervention seems to be disproportionately brought to African Americans than white Americans. And that is a bit of a concern. What about shared decision making? Now, among the audience, many of you may have heard this term. It certainly is coming out more often to refer to how we go about caring for patients, where we allow patients and request that patients play a more active role in helping decide how they would want to get their best care. Okay, this can occur for prostate cancer. It can occur for various other aspects of cancer management, cardiovascular disease management, various other aspects of care. And it refers to the fact that patients are given the opportunity to be informed, the opportunity to have a discussion, have an opportunity to help make their best decision. And this occurred very often in only 26% of African Americans versus 52% of Caucasian Americans surrounding the topic of prostate cancer. Again, evidence that suggests that men who are African American are not really given an opportunity to be cared for well, and there may be bias in terms of how we go about dispersing the best care for them. What about treatment delays? I put this down here because this often is brought up that many African American men are brought forward to have care at later stages of their disease, perhaps because of lack of access, lack of interest, lack of maybe the opportunity to get to see a doctor for various reasons. This has been suggested as a factor in decreased utilization of definitive care. In equal access centers, there is the suggestion that this may not be so. So for example, the military system, where soldiers are given equal opportunities for healthcare, it seems that, at least in some of the reports I've seen there, that African American men do have access and do get timely care. But this may not necessarily represent what occurs across America, and treatment delays possibly could still exist outside of these kinds of healthcare systems. What about the lack of treatment access, the big one here? Lack of health insurance, lack of available medical facilities. And I think this certainly is something that bears some discussion. Are African Americans availed all the opportunities because of our healthcare policies and healthcare system to get the best care possible? I think this is something that really, I think, is still in play as a factor that impacts the prostate cancer mortality among African American men. Here's some interesting thoughts. Systemic barriers. Many African American men are exposed to urologists less frequently. And where they have their geographic locations, perhaps in certain rural areas, perhaps in certain urban areas even, they may not have opportunities to see urologists. And the evidence is true out there that in areas that concentrate healthcare centers and have greater access to medical care, including urologists, that does not necessarily coincide with the African American population and where African Americans live. Here's an interesting report that I found on hospital racial composition. This makes the point that in certain hospitals where there are less urologists, okay, that is a point that this one made, but here also in certain hospitals where there are less, more advanced management, better MRIs, imaging, better testing, better care that's available, that there tends to be a high proportion of Black patients in some of those hospitals. And therefore, they receive less care just because they're not availed the very best of our latest medical advances for prostate cancer management. And there's evidence to suggest that this may actually be so, specifically for prostate cancer. So all of this is to speak to the topic of healthcare equity. Okay, disparities then reflect that we are not providing the best healthcare equity. And I think it can be summarized in terms of economic stability, okay, on all these different levels of prosperity, jobs, various kinds of job security, food security, living situations all play roles. Educational attainment, how far individuals, the African-American race, are getting properly educated and opportunities to understand disease states and receive the best care. Their environment plays factors in all of this. And this does come down to access to quality healthcare. So all of these, I think, to distill it down, I think, are some of the major variables that have to do with healthcare equity and inequity. And again, social determinants of health are the underpinnings of public health in the United States. So there is a difference between equality and equity. I think this cartoon nicely makes the point. Some would say, well, equality is to give everybody a box to stand on. Okay, that's equal. Well, if you're disadvantaged, you still don't get to see the baseball game. And if you're not so disadvantaged, maybe you see part of it. This all makes the point that equity refers to making sure all of us have access to see the baseball game. And this is the difference between equality and equity. Equity, it means that we should look for fairness and justice. Equality suggests that, yes, everybody has the opportunity to get the same thing, but if everybody is not given the same advantages, then that is not equity. And equity, I think, is where we need to accept that if everybody starts from different places and do not have the opportunities for the same things, then we're dealing with inequities or disparities, and that needs to be addressed. So this is my concept, hopefully concept of many, about how we need to really make sure we understand, for those who say, well, equality is everybody's given the same opportunities. That doesn't mean equity is being met. Okay, that's my point. Equity is not necessarily met just because of equality. Equity means we're doing the right thing, and for those who have been disadvantaged and unfairly treated in the past. So equity needs to be what we're striving for, not just equality. So how do we go about this? And so I mentioned in my early stage of the talk that I didn't want to just say what the problem is, but more than that, what is the solution? What are we going to do, and how are we going to take action? And I'm going to discuss with you a couple of things in the arena of prostate cancer that I do think fit with addressing the pattern of care, addressing the quality of care, and various sorts of progress is being made with research that we need to do, okay, along these lines. So pattern of care refers to early detection, diagnosis, treatment, access, both healthcare insurance, healthcare administration. We need to be able to think about how, with healthcare policy, we can improve the patterns of care. Similarly, the quality of care is not just offer these sort of things, but make sure that we do it well. Make sure that we do bring about the best quality. And I think that we're going to have quality indicators that are going to continue to come forward, having to do with the process and outcome domains of how we provide care that have to be met. Not just saying we're providing care, but how well we are doing this care. And I think this has to be emphasized. In terms of research endeavors, I think that we need to continue to understand what are the risk factors, particularly among African Americans, and how we can address these. And these risk factors can range from biology into tumors, genetics, and a whole host of other social determinants that we need to get busy with across all of medicine and all of general health, but certainly does have a role in prostate cancer. Now, we need to understand that the prostate cancer has different threats, and we need to help better able to define it, particularly if it's high-risk disease among African Americans. And we need to continue to make discoveries with biomarkers, technologies, and so forth. And so we are continuing to make strides, but we need to make sure that we bring these advances, to African Americans. So how are we doing this? Well, this is just a slide that shows you that from the American Urologic Association, its affiliate called the Urology Care Foundation is certainly making strides. I sit on the board of the Urology Care Foundation. I have to say I'm the only Black on that board, but nonetheless, my purpose is to try and make sure that we do a good job of helping address disparities in urology nationwide. And we need to put out various kinds of public education announcements for general health that range from cardiovascular health, lifestyle adjustments, understanding how to get your best screening for all health issues, and bring this forward. Understand what kinds of cancers out there, and understand that among prostate cancer, where there's a 2.5-fold greater rate, we need to continue to do these public announcements and be better able to bring about education and communication to our patients. And these kinds of strides through various organizations, not just the American Urologic Association. I'm just citing that since I'm a urologic surgeon. But I think that this sort of effort, we need to continue to make great efforts to do. As a urologic surgeon, I'm very keen about prostate cancer and have been for the past few decades. I wrote a book a little while ago. I don't mean to make this sound like a plug for the book, but just to make sure that I'm conveying the point that many of us who have the opportunity to get up a month in the front of an audience and to advocate for the best health of African Americans that we do. And this is a book that I wrote with a patient of mine to provide kind of almost a men's health guide about how to understand prostate cancer, all the way from how you get diagnosed and who gets it, all the way up to how you get treated. And so we continue to make these kinds of efforts, which I think are very important, to put out information that can hopefully positively impact those who are going to be disproportionately affected by prostate cancer. I should mention this book includes a number of my patients here, including some prominent African Americans who've had prostate cancer, and how they feel strongly about getting the message out. And that's the intent, to get the message out there. Now, how do we deal with prostate cancer? Speaking as a urologic surgeon, I compare that to breast cancer, again, which is a highly prevalent cancer in women. So this just makes comparisons here about how we go about examination, the digital rectal examination, how we do different tests like the blood test called PSA, how we stratify and determine the risk profile in terms of the aggressiveness level of prostate cancer, down to molecular markers, and various kinds of other ways that are starting to evolve, including genetic testing and use of other imaging techniques like MRI that's being used to screen for prostate cancer. All of this is just to make the point that I think that we are making advances that I think can address the disparate outcomes that Otis Brawley said, that as we make advances in medicine, are we leaving some individuals behind? And I think we need to understand particularly the genetic aspects of prostate cancer. So I'm going to just spend a minute or two on this. The genetics of prostate cancer is very important. And we're starting to bring along the idea of germline testing, that is, understanding that within all of our bodies, we have genetics that help us understand the threat of prostate cancer as well as for various disease states. And for prostate cancer, we recognize that there's more to it than just trying to get biopsies and understanding the threat of disease. In fact, that the concordance between a biopsy and a prostate cancer that we surgically remove is only about 55% in terms of all of the pathologic features. So there's a whole lot more to prostate cancer that we just don't have a handle on just by biopsies alone. We need to understand more about the genetics, is the point. And wouldn't you know that for prostate cancer, in terms of thinking about hereditary cancers, for prostate cancer, nearly 20%, 1 in 5, this is the actual rate, nearly 1 in 5 really have hereditary components to it, hereditary foundations to why prostate cancer occurs. And this is the evolution in our thinking. Breast cancer, and many of you have heard about the BRCA gene and various genes for breast cancer, that's about 12 to 14% associations with breast cancer. So prostate cancer actually has a greater hereditary association. We need to figure out what is the genetic basis, because as much as 1 in 5 men presenting for prostate cancer, it's because of genetic risk factors. And we're starting to understand this better in terms of the tumor biology, about the aggressiveness of disease, how it progresses, and how it claims lives. And we're going to go on to make more advances here that'll help with treatment decisions. We may have targeted therapies that are going to come along that will be able to identify what is the genetics for a certain man. And this is where the precision medicine will come in, developing specific targeted therapies based on different kinds of prostate cancers that are out there. And this may also is important, I just make the point that since it is such a prevalent disease for family members, that we need to understand this because it may help us counsel at-risk family members as well who have prostate cancer. I have a patient today I saw in my clinic. His twin brother came in with him today. He had prostate cancer, and one of the twins, we got his prostate out, and he came back just today to get his catheter out 2 weeks after his radical prostatectomy. I was thankful that his twin brother was with him, and I said, hey, Mr. Twin Brother, you got to get your PSA too, because if we think that genetics play a big role here, if your brother, who's a twin, just had prostate cancer and we got him in and saved his life with a surgery, please, please go out and get yourself screened as well. Now, some of the action steps that are being taken include such things as the CONDUC, the Consortium on Disparities of Urologic Conditions. The reason I bring this forward is registries are very important to understand the basic epidemiology, the basic statistics, the occurrences of prostate cancer, and how well we're dispensing care out there, the patterns and quality of care. And I have to tell you, that unfortunately, many of the registries that exist out there do not have a lot of participation by African-American men. Without that, we cannot understand really what is the threat of prostate cancer and how to manage it best. An example to you is that when the U.S. Preventative Services Task Force a few years ago proclaimed a grade D recommendation that only men between the ages of 55 and 70 need to be screened for prostate cancer, a lot of us Black urologic leaders were up in arms about this. Okay, in part because the studies that based this decision by the government did not include a lot of Black men in the studies in which this decision was rendered. And I think this is very unfortunate. And so a number of us Black leaders in urology have now convened across the country to put together a consortium. And what we want to do is develop this registry, and we started this now for various medical practices, from academic institutions to the VA medical centers, to major large urology practice groups, to try and make sure that we enroll men in these various clinical settings to get into this nationwide registry so we can better track the extent to which the various parameters and descriptors of prostate cancer can allow us to move forward and develop better recommendations for care. So that is a very key point I want to make about how in America, our Black urologic leaders are very keen about trying to do something better about what we're doing. This is a call to action. And we're developing this registry called the Scientific Consortium on Prostate Cancer Education. This is a registry, and we think this is going to be very important for us to describe trends of prostate cancer. Very important to understand that, particularly among Black Americans, to understand what are the risk prediction and stratification models so we can better understand how we can help men who come in who are African American, how we need to define their disease state and have better ways of bringing forward their best care. We want to assess quality of life outcomes, the various treatments that we're offering and how it impacts individuals in the African American community, risk factors that may be associated with treatment outcomes, and further develop and institute a network that will include both physicians and patients that will allow them to get involved with trials and get involved with the best care possible. I've mentioned earlier how we made all these advances with precision medicine and genetics. We need to make sure we bring this to the African American community. And this has been really the objective of CONDUC to do this. And so I bring this forward for discussion. You're going to hear more about this sort of thing. I think there's a very proactive attempt here with a call to action to make sure that we bring better care to our African American brothers out there. So by way of conclusion, this is from a book where I wrote a chapter. A couple of points. I think the elimination of pervasive and persistent racial and ethnic disparities will require a collective will that will involve healthcare organizations, clinicians, communities, patients that achieve healthcare equity. I salute the A. Philip Randolph Institute, Mr. Mason, and all the individuals who are involved in these kinds of activities, because I think this kind of collective will is necessary for all healthcare problems, including prostate cancer. And this progress is vital to overcome separate and unequal systems of healthcare that reflect implicit bias and contribute to unequal quality and quantity of life outcomes. As I mentioned, prostate cancer is the most common cancer among men in the United States, as well as African American men. But what's different among the general population is that it claims lives of our brothers 2.5-fold greater. And so we need to make sure we bring attention to this disease state. Not only is the disease going to affect about 1 in 9 men in general, it's 1 in 6 African American men. That is how prevalent this is, 1 in 6. And it takes away their lives 2.5-fold greater. So we need to bring attention to prostate cancer. And I do believe that healthcare equity is necessary to meet the needs of disadvantaged groups in the United States and achieve the best healthcare for all Americans. I believe this is so with prostate cancer. That's how I got involved in this field, because I realized early in my medical career that this is where we need to have great impact. And I certainly have committed myself to address prostate cancer disparities and continue to try to do that over the years. But again, it's a collective effort, and I appreciate all the individuals who are making advances in this field. So I will stop there, Mr. Mason. That is my presentation, and I hope that's been impactful and informative. And I'm glad to field questions at this point.
Okay, Dave, am I on?
Yes, you're on.
Okay. Well, thank you so much, Dr. Burnette. And you know you're going to have to come back again, right?
Absolutely. I'm always delighted to do so.
Wow, because that was just so much good information, provocative information. And I have a little paper here with a whole bunch of questions, but that's really not my job. And I'm sure that Jada probably has some questions in Q&A or chat, so we can do those first.
Yes, we have one question in the chat right now that says, is there a specific diet that will help avoid prostate cancer?
Thank you, Jada. So the question is there a specific diet that would be recommended? And the answer is that important question to ask, because it suggests to me that we all want to take action, and what can we do on an individual level that may have impact. And so we've, in our field, thought about this, have done various studies. The best that we can say at this stage is that a diet that involves less of red meats, less food that's cooked on a grill, all the food we love to eat, less fatty diets, and a more balanced diet with fruit and vegetables probably has positive impact in terms of cancers in general, and certainly in prostate cancer. I can't prescribe to you that a certain food that you have to eat, let's say 5 days a week or something like that, is going to be the way to go. But I think a more balanced diet that includes fruits and vegetables, less of the fatty foods, less of the red meats. Most in our field believe that there is some epidemiologic studies that support this. And that would be my recommendation, a better balanced diet in general.
That is all we have in our questions for right now.
Okay, does that mean I get to answer my 45 questions?
You're up next. I guess I'm on the hot seat too. Tell me what's on your mind.
Well, one of the questions, and I'm reflecting on when we did this discussion in St. Louis probably about 7 years ago, and talking to some of the brothers that were in the Brothers Only, that there was a skepticism about getting tested, because folks thought that the test, and I guess it was what, the DRE test, was too invasive, and it got crossways with their cultural outlook.
Well, let's talk about that. So the DRE, which refers to digital rectal examination, okay, I showed that on the slide as one of our basic tools for diagnosis, has historically been one way in which we pick up the diagnosis of prostate cancer. I can tell you that back when I trained in the 1980s, as I was beginning my career as a urologic surgeon, we did not have PSA testing. PSA refers to the blood test. It stands for prostate-specific antigen. And this refers to a chemical that's released from the prostate, and only prostate cells make this chemical and gets in the bloodstream, and we can measure it in men. And the numbers have a certain normal range, and if it gets outside that range, we get concerned that something's not right with the amount of PSA that man's showing that his prostate is making. And the higher the number, we worry about prostate cancer. Back in the era of 1980, we only had digital rectal examination. We didn't have PSA. It came out in 1988 as a test that we could use. In that era of time, we did rectal examinations because we felt something irregular about the prostate, particularly something hard that did not feel like a normal smooth prostate. We were very concerned to say, let's move forward to get a prostate biopsy. And in that era of time, when we made the diagnosis, we were probably only curing about 2 out of 3 men who we made the diagnosis in that period of time. 2 out of 3 men. And that means that feeling something unusual or hard about the prostate meant that the cancer was progressing enough that it's a late diagnosis. Now, in the more modern era now, we have PSA testing, and in the majority of men, we pick up prostate cancer based on that blood test. But I can tell you the statistics still show that the PSA test is not infallible. I mentioned the PSA test, that if it gets outside a normal range, we get concerned that a man's prostate should make just enough PSA. And if we see that number range, which is between 0 and 4, that typically is the normal range with some caveats to all that. And if we see a value that gets above 4 with your PSA, again, for the audience hearing that, then we get concerned. And that may then warrant a biopsy of the prostate. And many times that'll allow us to pick up the diagnosis much earlier than we did just 3 decades ago. That's the good thing if you get your test, get a PSA test. So that's still a very valuable test. And most of the time we will make the diagnosis based on that. And perhaps the digital rectal examination is not completely necessary to the extent that most of the time we'll pick up prostate cancer based on that blood test. So I want to emphasize the PSA test. You know, a little additional remark is that, yes, about 10% of the time we may find that the PSA does not reveal prostate cancer. And that man got his prostate checked, and thank heavens we felt something suspicious on the prostate exam that did prompted us to say, get a biopsy on that basis. So the reality is about 10% of the time, the PSA may not go up as high and prostate cancer is still going on. Okay, so I mentioned that statistic just to say that most of the time, the PSA is going to be informative, but not always. And that's why the digital rectal examination, for completeness sake, we still say, if you want to get checked as completely as we can for screening, get your PSA and get your digital rectal examination, but at the very least, get your PSA. So that's the word to be said. I can't help but also echo the concern here, Mr. Mason, that men don't want to have somebody put a finger in their bottom and check their prostate. That just is either uncomfortable or they're just unsettled by that as a man. They don't want anybody doing something that sounds homophobic and that kind of thing. But as I can tell you, as a urologic surgeon for the past 30-something years, I don't take any delight in doing the exam either, if that gives comfort out there. But I do it because I'm dedicated to my patients. And I realize 10% of the time, prostate cancer might be developing even when the PSA is normal. And they say, Dr. Burnette, just do all the right things you got to do. I'm going to check my PSA and I still want to get my prostate checked. So that gives you some discussion surrounding this whole topic that, yes, the DRE, the digital rectal examination, is starting to go by the wayside. Okay, PSA test is dominating. Get that PSA test. But at the same time, there may be some men out there that the PSA does not always correctly lead to us getting the workup, because it may still be in the normal range and prostate cancer might still be developing.
Jada, I think I saw a question from President Brown.
Yes, we have one question from her that says, is it true that the testing should be done earlier and more regularly for Black men because of the differences in detection?
Well, I'm glad that discussion came up. And I was thinking that the audience may bring this up. How do we go about the best recommendations for screening prostate cancer in Black men? And that's the question. And the answer is this. You know, I alluded to this, that the U.S. Preventative Services Task Force issued a kind of a guideline statement that no man needs to be tested unless he was between 55 and 70. What does that mean? Well, that means that we think prostate cancer more commonly affects men in that age range. And maybe after age 70, we say stop doing it because prostate cancer developing at later ages may progress so slowly that it may not be much of a threat. The problem with those studies, as I mentioned, that led to that analysis and that proclamation is that the studies that were done having to do with screening for prostate cancer did not have many black men in those studies. And therefore, it doesn't really refer to the black population very well. And so thinking that if you consider this recommendation of only men between the ages of 55 and 70 should be screened, I do not believe, and many of the black urology leaders do not believe that should be our recommendation. Those men who have a higher threat of prostate cancer, which includes African-American men and men with strong family histories of any racial background, should not adhere to that recommendation. Should not adhere to that recommendation. And I think that what we historically had said, all men after age 50 should get a PSA. I think most of us African-American urology leaders, would make it very clear that we're going to recommend that African-American men at age 40 should at least get a PSA, at least get a PSA then. Get a PSA, know what your PSA is, like that announcement from the Urology Care Foundation, know your PSA. Get a PSA at age 40 and know what it is. And if it comes back anywhere in the high range, close to 4 even, you should probably go see a urologist. And many times, yes, many of African-American descent are going to have PSAs that climb higher, even in their 40s, that we don't see in white men. That's the point I'm making. And so the cancer occurs earlier in many black men. And for reasons we don't fully understand, the biology of prostate cancer, the tumor biology and the genetics are things that, yes, we're doing registries to understand this better, but at least as we've made observations, it does appear that many more young men of African-American descent in their 40s have high-risk prostate cancer. Therefore, we cannot tell people to wait till they're 55 to get screened. We need to tell guys, get your PSA when you're age 40, at least discuss it with your regular doctor, and then based on that evaluation, it may be so low in the one range, we might say come back in 5 years, and that's fine. But at least get it to know where it is, because I see many guys in their 40s who are African-American who have PSAs that are already going up in a significant way. We get them biopsied, get biopsies done for them, and prostate cancer is taken off. And if they waited till 55, they might not get to 55. And so the current recommendations is age 40, get a PSA if you're African-American, because this population is very different than the general population that was the basis of the earlier recommendation by the U.S. government. So I think we have to revise some of that thinking. It doesn't address all populations is the key. And age 40 is what I'm going to recommend, because I think that's where many of us in this field strongly believe African-American men should at least get a PSA to start. At least get a screening PSA when you're 40.
Wow. Jada, are there any more questions in the chat or the Q&A?
No, there's no more questions.
Well, so everybody give Dr. Burnette a big virtual hand clap. That was fantastic. A wealth of information. And you did promise to come back again, right?
Oh, absolutely. It'd be my honor and my delight to do so.
And one of the things that Dr. Burnette is also famous for is treating erectile dysfunction in men. And he's a pioneer in that field. And so, we will have that discussion when you come back.
That's so important, Fred. One of the reasons that's important is too often with the implication that getting treated for prostate cancer takes away a man's sexual function. I think that has been an issue for many African-American men to say, I don't want to get tested because if I get treatment with surgery or radiation, while it may treat the disease, I may lose my sexual function. Yeah. Of course, that's a hot button, this topic. We can spend an hour talking about all of that.
Right.
The issues surrounding a man's sexual function and how we should recognize where we are in the modern era with our treatments. We need to think about how we've made advances both with radiation and surgery, so that the effects of treatment, I think, are far less worrisome. And if a man does get treated, you know, what options we have to enable him to continue to have that intimacy with his partner and have sexual function. As one patient told me a while back, he said, Dr. Burnette, I know I've delayed getting treated for my prostate cancer, and I realized I got to move forward here because I was worried I was going to lose my erections and my function. But I came to realize that the ultimate form of erectile dysfunction is death. So I got to stay alive. And I said, well, that's what I've been preaching. You got to stay alive if you're going to be there. And realistically, you have to be there for your family and your loved ones. And so please don't deny getting your workup. We can address sexual dysfunction issues in the field of urology, but we can't have our brothers die out there because they're just fearful of getting treated for worries about their sexual function. We can still address that. So we can bring that in for a discussion another time.
Okay, and thank you so much, Dr. Burnette. Thank you, and I look forward to having you back again. And we really appreciate it. And I thank all of the APRI family and friends for tuning in, and look forward to seeing folks next week. I just saw a message from Jan, but it went away.
Yeah, let me see if I can see. I can quickly address it. I think it had to do with. Some of these had to do with what is imaging for men for prostate cancer that are similar for women having mammograms. And again, this is the prostate MRI that I showed on that one slide that we're advancing now to use the MRI study to help us define the way the prostate tissue looks, and that may be useful for that. For that addressing.
Okay. Well, thank you for answering that. And we got about 3 minutes that we need to cut this off before Dave starts yelling at me. But again, thank you for that wealth of information, Dr. Burnette, and thank you, audience attendees, for your patience with this. And one day, we're going to finish in a half an hour. But the information is so good that folks always have such good questions until we go over, but it's our program, so we can do that. But again, thank everybody. Thank you, Dr. Burnette. Thank you, audience. Thank you, Dave, Al, Jan, Jada, President Brown, and I saw a couple other board members. Thank you.
Well, thank you. It's my delight.
Okay.